we developed this whole model-based selection procedure to get proton therapy introduced into the Netherlands. At present, the Netherlands is the only country in the world which has adopted officially this kind of method for selection of patients. It's very important that we share our thoughts how to select patients for proton therapy in a more evidence-based manner with other countries and with our colleagues. I think it's a very good methodology which really enables us to select those patients for proton therapy that will benefit most of it, and that's important for everyone. And for new radiation technology, especially when it is more expensive, it is extremely difficult to perform a randomized controlled trial. First of all, you need the technology, which is not available, so you cannot do a randomized controlled trial. It's much more expensive and it will not be reimbursed, so you need a lot of money to do those randomized controlled trials, which is very, very difficult to do. So this committee asked me, can you come up with an alternative methodology? And so that was how we developed the method. So what the method does, it tries to select those patients that will benefit most from proton therapy in terms of reduction of radiation-induced side effects. So what we do, we develop models. These models describe the relationship between the dose distribution that you can obtain with different radiation techniques. You can also try to optimize your treatment using the information from these models. And then you can try to compare one technology with another technology and see which of the two technologies provides the best results with regard to the dose distribution. And what is a very important step in this method is that we do not only look to dose reduction, but we use the same model then to estimate the benefit in terms of reduction of the risk of that specific side effect. And then you just have to define a kind of threshold. So you can say, okay, in this case, proton therapy would provide a 10% reduction of the risk of tube feeding dependence for the rest of someone's life. So we think that it's a clinically relevant difference, so this patient can be selected for proton therapy. So I think it's a very nice example of personalized medicine using individual patient data for the selection of the most proper treatment. Well, I think that this methodology can be used anywhere. What is a problem in the whole discussion is to define the threshold. So what kind of threshold are you going to use for the selection of patients? So the insurance companies in the Netherlands say, well, we only want to reimburse those treatments if there is really a matter of cost-effective treatment. And if that's not the case, you cannot do it. I think that is not, it could be a good way to think in some circumstances, but sometimes that's not a very good thing to do. For instance, in breast cancer patients, we have now models from a very recent publication in New England Journal of Medicine, which clearly showed that there is no threshold dose for myocardial infarction after treatment of breast cancer. So every gray matters. So now the question is, what kind of thresholds are you going to use for the risk of radiation-induced myocardial infarction? And 20% of these patients die from myocardial infarction. Do we use 1% lifetime risk? Do we use 2%? Do we use 5%? That's a very difficult question. And that's the main challenge. How are we going to define these thresholds for the different indications? It's a bit a limited way of thinking to say that randomized controlled trials are the only way to make decisions, because I think 90% of the decisions we make in medicine are not based on randomized controlled trials. There has never been a study that proved that if you have breast cancer, you have to be operated upon. We just started to operate on these patients, but it has never been randomized. So do we say we do not treat patients with breast cancer with surgery anymore because there is no randomized controlled trial that showed that? That's a ridiculous way of thinking. So I think in some cases it's a very good principle to use randomized controlled trials. But for certain circumstances, it's not the most optimal way to decide on what is the most optimal treatment for specific patients. I think it's a very important point because what you see, at least in my country, that many radiation oncologists do not know very much about proton therapy. If you ask them what is the indication for proton therapy, they say, well, children, pediatric tumors, base of skull tumors. But if you ask why is that, many of them do not know why proton therapy is much better, and they do not realize that the superior beam properties of proton therapy as compared to photons offers unique possibilities to get a better conformal dose and to especially reduce the side effects of radiation.